Good afternoon. I wanted to, first of all, greet you all and thank you for coming today at the end of this year. And I wanted to also thank you for your continued support of Right Care at University Best Practices. Wanted to take just a few seconds to also thank Diane Little and Sierra Health Foundation for the support of continuing to allow us to use this wonderful facility and to provide lunch to us. It's a great partnership, and I know this has a special place in Sierra Health Foundation's program. And so thank you, Diane. We really continue to appreciate all of the great support that Sierra Health and you do for our continued discussions. So today, wanted to have a special treat. Dr. Rodney Hood has come all the way from San Diego again, and I think he was one of the key partners that helped create the Right Care Initiative in San Diego as well. And Dr. Hood has been the kind of lead medical director and chief health officer for multicultural IPA in San Diego for 24 years. I want to especially thank Dr. Hood for coming now, because this is actually kind of a difficult time for him. Unfortunately for many of you who knew his partner, Dr. All of a sudden I'm blanking. Butcher, Dr. Butcher, Richard was his first name, helped create the multicultural IPA, and unfortunately, a big hit to our community, to California and to San Diego in particular. Dr. Butcher passed away 3 weeks ago, suddenly, while he was working, attending the AMA meeting. And so I know this is a very difficult time for you, and I want to tell you our condolences and thank you for kind of doing this and coming all the way out here as well. Dr. Butcher has done a tremendous amount of work as a leading multicultural IPA, one of the best IPAs in the country. And some of the work that he's done around diabetes care and hotspotting is actually advanced work, leading edge. And so he's going to share with us about the work that they've done about 4 years now with hotspotting and with better care for diabetic and heart disease for the high utilizers in the community. So, Dr. Hood? Dr. Hood?
Dr. Rodney Hood, welcome.
Good afternoon, everybody. I am going to talk, the topic is about hotspotting, diabetes, and heart disease. But this whole experience in the past 4 years has been a lesson for me and some of the docs of the IPA that we work with, in that most of what we found about was that, especially when you're talking about hotspotting, and I'll explain what that is, by focusing on social determinants of health and helping patients overcome the barriers of the social determinants of health, we see improvement in chronic diseases like diabetes and heart disease. So, my first slide is a slide of Dr. Jeffrey Brenner. How many of you in the audience have heard of Dr. Jeffrey Brenner? And, Dr. Brenner, I was fortunate enough to meet maybe about 4 or 5 years ago. And we kind of called him the father of hotspotting. He was a family practice physician back in Camden, New Jersey. He was independent enough physician in a very poor area of Camden, New Jersey, and got off into hotspotting really by accident. There was an incident outside of his office where a young man was shot, and he went outside, tried to assist the person. Actually almost got into an altercation with the police because he didn't really feel that they were giving the man the care that was needed. And long story short, he started, the man was taken to the hospital. He had been in the area several years, and it led him to say, you know, I've had my practice here, and I'm seeing a small number of patients continually going to the hospital over and over again. And he began to analyze the data at the hospital and discovered that 36, what he called super utilizers, those are individuals that utilize medical services higher than anybody else, cost the system $1.2 million every month. And he got the idea of putting together a community-based intervention team that focused on those 32 super utilizers. And over a period of time was able to show a decrease in cost from 1.2 million down to 500,000 after this intervention. So this was about 10 years ago. So CMS at the time of Obamacare formed the Innovation Center, and they said, you know, that's interesting, we're interested in cost savings, can that be duplicated? And so I actually went back and visited him in Camden, New Jersey, and Camden, New Jersey is a lot different than Sacramento, a lot different than San Diego. It's very urban, people live in a concentrated area. As a matter of fact, he was able to identify 2 project-like structures where a significant number of the patients who were considered hotspotters lived. And so his approach was to set up a clinic in those buildings and actually gave them a primary care site to go to. However, in San Diego, that's really not the issue. So our challenge was to adapt this model to a geographically diffuse and fragmented health system. Several years ago, Dr. Brenner actually won the MacArthur Foundation Genius Award. And those of you who don't know about him, I believe you will soon be hearing a lot about his work. So this is the medical group that myself and my colleague, Dr. Butcher, founded about 23 years ago. It's called the Multicultural Medical Group. And in July of 2012, we were awarded a 3-year, $1.2 million grant from the Center for Medicaid and Medicare through the Innovation Center to see if we could be one of the sites that tried to replicate or duplicate what happened in Camden, New Jersey. There were 4 sites other than Camden, New Jersey that were part of this grant. I believe it was Philadelphia, Colorado, Kansas City, and San Diego. And very diverse group. What was unique about San Diego, we were the only group in San Diego. We were the only independent physician IPA, for-profit, that was involved in this. The other sites were federally qualified clinics or associated with large health systems. And so what was interesting is I remember going to my board and trying to convince them that we had a grant. And it was about a 2-hour discussion trying to convince them that it wasn't going to cost us any money. For those independent physicians in the office, you know, we're very self-centered about our own practice and how much is it going to cost. And so they see a federal grant coming in, and it took a while. Then the other conversation was with a management service organization, which was Cinnamon, which is an entity that manages our IPA and has done so for the past 15 years very successfully. And I had to talk them into managing the grant financially, really at no cost. So after we convinced them to do that, I stated it potentially could save us a lot of money. I didn't know that, but I was trying to sell it to them. So the purpose of the grant was to see if we could achieve the triple aim, which was improve access, improve quality of care, and show some cost efficiencies. So the whole concept of hotspotting is we spend $3 trillion on healthcare in this country every year. 1% of the patients that we treat account for 25% of that cost, and 5% account for 50% of that cost. 95% of the patients that we treat account for the other 50%. And so therefore, if you focus a hotspot on the highest utilizers, although the numbers may be low, you're going to have the potential of making a great impact financially and on that patient that you're focusing on their medical outcomes. So that was the concept. Now, I'd like to say the main reason why CMS did this was to improve quality and to improve access, and that's clearly what they said. But I can tell you during the grant, they were really concerned about are you saving money. It was all about the money. So these were the criteria that we used to enroll patients. If they had 2 or more hospitalizations in the prior 6 months prior to enrollment, 2 or more emergency room visits in the prior 3 months, complex pharmaceutical regimens with multiple medications, multiple chronic diseases, and a willingness and ability to participate. Probably the most significant one was the last one, willingness and ability to participate. Because if they weren't able or they weren't willing, it was difficult to have a success. So those were the criteria. Initially, the reason why the multicultural IPA was chosen, we're about 150 primary care physicians, 200, 250 specialists. We have maybe about 70% of the county of San Diego, but most of our docs are focused on the central south area of San Diego. And we are, like our name says, very multicultural physicians and very multicultural population. And the data showed that where we were had the highest incidence of heart disease, hospitalizations, diabetes, etc. And based upon that, I was approached because they wanted to see if we could have any significant impact in making a difference. So the grant started in 2012, and it went until 2015, so 3 years. When we started the grant, we have an IPA, and the function is, everybody understands the IPA model, but it became clear to us if we wanted to sustain this. What we learned quickly was that most of the intervention that we were doing was social rather than clinical. We were doing both, but most of it was social rather than clinical. So we formed the Multicultural Health Foundation because we wanted to get other grant funding that would help us build the infrastructure to continue to do the social intervention. And we wanted to build the business model, the financial model, that if we did prove there was savings, we could go to those entities that had the savings and maybe contract with them moving forward after the grant. And we were up to 4 sites. I think we were one of the sites that had a success. The grant ended in July of 2015, and we were one of the sites that was able to go on because we were able to develop a sustainable model. So in 2015, our program in San Diego was called the Physician Health Improvement Initiative, so we called it the PHIIT. You can see it was a small team. We had a couple of nurses, LVNs, RNs. We had some call them patient navigators, community health workers. They were trained in the social services. And then we had an administrator, so it was a very small team. So at the end of 3 years, we had enrolled of all the 4 sites, we had the smallest number of enrollments because the others were much larger entities than us. So we enrolled 165 patients. Most of them were in low-income neighborhoods. We accepted patients from a variety of providers and systems. In San Diego, many of the IPAs are associated with systems. So they're associated with the Sharp, Scripps, the university. The multicultural IPA is truly independent. And many of our patients, none of the doctors are exclusive just with our IPA. So many of their patients come from many of the different systems. We provided intense intervention services that lasted on the average of about 6 months. So each patient who was enrolled on average of 6 months. Some were enrolled shorter, some were enrolled for over a year. And the care team conducted every patient got an initial evaluation, usually at home, that lasted 2 to 3 hours. And it usually consisted of at least 2 individuals, many times 3. We had a nurse that did the clinical evaluation. We had a social worker that did the social evaluation. We developed a social intervention plan, a clinical intervention plan, and goals. Our goals and the patient goals. And many times they were accompanied by a volunteer. We call that our secret sauce. And the volunteer really helped us follow up on these patients. We developed these plans, we connected patients to vital services, and over time discovered that maybe about 70% of our interactions were social rather than clinical. Need of transportation, food, financial issues, and I learned more about our social structure in the past 3 or 4 years, and I've been in practice 40 years, than I knew in the past 40 years. I learned more about my patients' social issues through this grant than I ever thought I would know. If we know it's complicated, but it's worse than I thought. And what I developed an appreciation for was the team approach. I don't know how we physicians, and especially those of us who practice in an underserved area, where we're dealing with patients who Dr. Brenner said, we don't want to use the term non-compliant, because most patients, once when you give them the resources, are eager to be compliant. So we call them under-resourced patients. And as we helped them with the resources, they became more compliant. The volunteers contacted patients at least weekly and became the health advocates. So,
Who were the volunteers, Dr. Hill?
So the volunteers were, first of all, Dr. Brenner started his program on the East Coast with a group called PICO. They're a group of community organizers who are faith-based, and they have chapters all over the country. One is in San Diego called the San Diego Organizing Project. So these were community health workers that were associated with many of the churches in the area. So some of our initial volunteers were from the community, from the faith-based community. And the other 3 years I recruited, I'm also on the staff of UCSD Medical School, and recruited medical students and pre-medical students. So they were a community-based, pre-med, and med student. And depending upon the time, we had anywhere from 5, 6, up to 25. So what our challenge was in our population was, it was multilingual, multi-ethnic, low income, scattered in a wide geographic area. Dr. Brenner's program, patients were in a concentrated area, set up a clinic. Well, we didn't have that luxury. We were all over. So The staff is going to the homes, all kinds of hours. They served a fragmented system of private docs. We enrolled patients from federally qualified clinics. We enrolled patients from other health services. So when we first started this, I thought we were just focusing on the patients within our Independent Physicians Association. And we're contracted with health plans. 99% of these patients were insured. So what we found out is that we were enrolling patients that were already on the radar of the health plans. They're already in the case management systems. And we started having communication with the health plans, and over time set up monthly and then weekly conference calls on these patients with the health plans in their case management team. And what they found out and what we found out was that their case management system, most health plans have some type of chronic case management system which is effective, but a subpopulation of superutilized, we found our program was much more effective. We were much more intimate. We're on the phone each week, and the case management said, well, I've been trying to reach Mrs. Jones for 2 weeks and I haven't. And my nurse would chime up, well, I just visited her yesterday. And here are her problems. And here's what we need. The medical director of one of the health plans pulled his case management team along kicking and screaming because initially they saw us as competition. They thought we were going to take the job. But ultimately what they found out is that there's a subset of patients they didn't have, I don't want to say they didn't have a clue, they didn't have the resources. They're kind of like telecommunication, we're in the community. My office is located in Southeast San Diego. The team works out of my office, but I call it the virtual patient-centered medical home, where we're there, but they're not tied to my office. This is the profile of the 160. The youngest was 16, the oldest was 92. The average age was about 60 years of age. They all had at least 5 chronic diseases. Of the top 5 diagnoses, cardiovascular disease and diabetes were in the top 3. At least over 4 ER visits in 6 months, over 2 hospitalizations in 6 months. 85% had behavioral health illnesses, 15% needed housing, 66% needed transportation, and many had poor nutrition. So these are the patients we're dealing with.
That's a stunning number, the 85%. Can you elaborate on that? Behavioral health illnesses, comorbidity?
I don't know for any physician that should be stunning.
85%,
As primary care physicians, anybody surprised at that number? I mean, if you're in practice long enough, and if you're paying any attention to your patients, okay, we may not deal with it well. We may not deal with it well as primary care physicians. But, so that number honestly didn't surprise me. How can you put it? Sometimes when we're not that effective, we have this bifurcated health system where we have mental health over here, and physical health over here, and all these patients had access to some type of behavioral health services, but it was fragmented, culturally inappropriate, difficult for them to reach, and many times when they were engaged, I didn't know what was going on. They were unhappy. I wasn't getting any reports. So you kind of ignore it. You kind of know they're going. But through this program, we became very intimately involved in what was going on because our teams were actually going with them to their visits. So our teams not only visited their homes, they went to the primary care, to the specialty visits. They helped them get transportation. They would help them get What's the program for food? CalFresh. Yeah. I learned more about CalFresh and applying for CalFresh, who can get it, who can't, and then if they weren't able, places in San Diego where they could get food. Sometimes our patients usually weren't, I would say, you see down there it says 15% needing housing. That's not necessarily homeless. They were just unstable. They were inappropriate housing. We had a few who were homeless. They actually visited them on the street and in various places. But many times the housing or where they were living was totally inappropriate. So we spent a lot of time trying to find appropriate housing for them. And each week, we all gathered in a room, and we had talked about each patient. Interesting thing, these patients have 24/7 access to our care team. Now, I didn't really plan it that way. We didn't really plan it that way. What happened was most of the individuals who we hired for our team were very seasoned nurses, social workers. They had been in the health field for a long time. So there wasn't much they hadn't seen. However, they developed such a rapport with the patients that when they started calling them after hours, when they started calling them on the weekend, they were responding. And during the meetings now, I was concerned about, oh God, are we going to have to stop paying overtime? Where are we with this? All of them were independent contractors. So on their own, they were giving the patients this time. And so after about 6 months, I started asking them how often and to document how much time above and beyond 5 or 6 p.m. they would be in contact. And I don't know if the data is here, but I'll show you that. What I loved about it was that they saw such a change in the patient. They felt that they were making such a difference versus when they were working in the hospital, just working in a doctor's office, that they really gave to the patients. They really developed that trust with the patient. The patients were being seen or talked to at least once a week. Over the, I think this is about 17 months, there were 40 contacts with each patient, totaling 20 hours. The team checked in regularly, and we had regular meetings with health plans, health plan case managers, social workers, and participated in weekly coordinated care meetings. So we would have on the phone our patient health improvement team in person. On the phone would, say, be another health plan. HealthNet was one of them. Their case managers and medical director would be on the phone. And then our IPA case managers, CIMNET, would be on the phone. And we're all talking about the same patient. And the benefit of that was when the patient, sometimes just getting access to benefits, a wheelchair, a walker, a shower chair. If as a primary care physician, we had one patient was in and out of the ER, had an electric wheelchair, his electric wheelchair broke. He had been trying to get the health plan to repair it because he couldn't get out of the house. So when he wanted to get out of the house, he'd call 911. And he had an indwelling Foley, so he always had a urinary tract infection. And that would help him get out of the house. And on his way back, he'd either get a ride or a cab. He'd have him drop him off wherever he wanted to go before he went back to the hospital. I mean, it was amazing. When we explained that to the health plan, he had been trying to get this wheelchair fixed for about 8 months. They looked at the cost, and in 2 weeks, he had a new wheelchair. 2 weeks. So this is some of the demographics. Of the 165, 41% were Black African American, 22% Hispanic, 24%